Our next speaker is Ambassador Deborah Birx. Dr. Birx has dedicated her life to improving the health of others around the world through the development of diagnostics, therapeutics, and vaccines, and critically the use and integration of big data to end pandemics around the globe and promote global health security. She's also served as the White House Coronavirus Response Coordinator, bringing together years of research and development experience in diagnostics, therapeutics, and vaccines, along with her real-life experience combating pandemics. At this point, I would like to turn the floor over to Dr. Deborah Birx, who will present on COVID-19 USA, lessons and new tools to improve workplace safety. Thank you.
Thank you, Kevin, and thank you for the introduction. I am in London and I have an iffy internet. I will turn myself off and just talk rather than having video, if that's okay. First, I just wanted to thank each and every one of you for the work that you do every day. It was such a privilege to be able to be out in the States during the height of the pandemic and really see what was happening with our frontline healthcare workers, what was happening on the front line, and what was happening in the United States. I had worked the last 20 years battling HIV, TB, malaria, Zika, avian flu, and Ebola around the world, and came back really to work on COVID-19 domestically. But it was a real baptism by fire, and I just wanted to go through what I have learned. So pandemics always create inflection points. And we've seen this with the HIV/AIDS pandemic. We've seen it with other pandemics. With this pandemic, I believe COVID will have changed healthcare delivery forever because we had amazing innovation at the front lines, because hospitals had to innovate to really save people's lives. And so that created a lot of new tools. In addition, we have expansion of at-home diagnostic tests, and that also gives us additional tools when you combine that with telehealth and really understanding how to use diagnostic testing from the home along with telehealth to really reach all Americans, including Americans, particularly in rural areas that I'll be talking about, whether they're Black, brown, white. Our rural healthcare system over the last 20 years has really fallen apart. And that was really quite evident when I got out into the field and out in the States of what was actually happening. But we also saw incredible innovations, new ways to transition clients from hospitals to rehab, hospitals without walls, where hospital personnel kept track of individuals with O2 sats and other vital sign monitoring at their homes, and then integrated dashboards across previously competitive hospitals. And I think a lot of this was lost in the politics and the finger pointing. I really saw amazing dedication at the level of the hospitals to create new ways of working together to ensure patients had access to ECMO or other highly technical interventions that were needed. The Chicago area hospitals and several others created this transparent dashboard so that every physician at every time could see where was the technical capacity that their patients needed. And I'm hoping we don't lose any of that. But the pandemic also laid bare, and many of the issues still exist today and leave us incredibly vulnerable. I know this list is long, but fundamental to our difficulty is attempts to continue to create a parallel public health system with limited public health data, separate from the care provisions organizations of the United States where care is provided. Whether it's our clinical laboratories, whether it's our clinics, our urgent care, our emergency rooms, and our hospitals, we have to find a way to anonymize that data so that all community-acquired infectious diseases are diagnosed with a laboratory test, not a presumptive diagnosis, and that we maintain those clinical databases independent of trying to create a parallel public health system. Because we attempted to create a parallel public health system, unfortunately, many of the lessons we learned early on in COVID, lack of test availability, lack of data, was played out again in our monkeypox response. Even though we had a therapeutic and a vaccine, we were slow to act. act, we were slow to test, and exactly the issues that I saw in January and February of 2020 were played out again in the summer of 2022, showing us that we are still not learning the lessons of how to confront pandemics. We saw the monkeypox from the vantage point of the UK, who really provided us data in real time. And again, being slow to test, slow to vaccinate, and slow to clearly communicate put many more Americans at risk, particularly among our LGBT community. America must recognize that this is not a funding issue, but an integration and focus issue. And we must move past this 19th century concept of public health to a 21st century population health that utilizes all the electronic tools that we have available to us. We need a new level of cooperation between our public sector, our not-for-profit clinical sector, and our for-profit healthcare delivery system. The pandemic also laid bare huge issues with access to primary care, both in urban pockets, but also in rural America. And we need to rethink frontline healthcare workers to include the additional elements of community health workers, mental health workers, and fund peer outreach and education, including behavioral research. We need a more durable COVID-19 vaccine, and we need additional antivirals beyond Paxlovid. I'm very worried about the generation of potential resistance with these cases of rebound. And then we have a continued threat to our healthcare workers through continued community spread, leading to high absenteeism during surges and the potential of continuing cases of long COVID, leading to increased disability in our workforces. The level of long COVID among our healthcare providers has not been adequately studied and needs to be. So, and there is still the fall coming. So what are my biggest concerns for the fall of 2022? Viral escape from Paxlovid. So we need to reconsider a 10-day course, particularly for those over 60 and those with severe comorbidities, because those seem to be where most of the rebound cases are occurring. We also need to understand the Australian flu season, and I'll talk a little bit about that. If we have an overlap of even a normal flu season and with even a diminished COVID surge in this fall and winter, we will again overwhelm hospitals and their staffing. There's a clear need to expand COVID and flu testing. And right now, we are already seeing rising COVID cases in elementary schools. We know what that sequence is. Elementary schools lead to infections of the teenagers, which leads to infection of parents, which leads to infection of their parents, and then leads to widespread community spread. And this is what we need to really be able to test for. Every hospital, every community needs access to combination COVID flu testing for definitive diagnosis. I'm sure you're all following the evolving loss of the effectiveness of EvoShield against the B4 Omicron variant. This will also be a critical issue, particularly for those who cannot mount an effective immune response to the vaccine. I do believe there's an immunologic consequence of including the original variant in the fall COVID booster, because it will distract from our body's ability to see the new Omicron-specific antigens. If you have not been infected with Omicron, I know a large number of Americans have been, but there's a large number of Americans who still have not been infected with Omicron. So when they see the original strain in the booster, they will preferentially increase that immune response to the original strain. And I think there'll be less immunogenicity of the Omicron variant. And then for those of you in the healthcare industry, we need to look carefully at this 5-day return to work without testing. I do believe that's leading to cases of COVID within hospitals and hospital patients. We know now that people remain infectious out to 9, 10, and 11 days. And I think we all need to have a level of responsibility for that. So we have solutions though. And I think what we all should be focused on are the solutions that we know work. Certainly we know vaccination does work, but really a key need to continually boost, because protection seems to be waning now within weeks. Waning to infection first, and protection against infection, and then to severe disease and hospitalization. Testing becomes absolutely critical to identifying early cases because it ensures rapid access to Paxlovid. I'll cover the flu cases in Australia. They had a normal, and I mean normal seasonal flu for the first time in 3 years. It was equivalent to their 2018 and 2019 season. So we believe, based on the Australian data, that flu and COVID will be circulating for the first time this fall, and it makes testing critically important. There's also the issue of monkeypox, and for staff unknowingly bringing monkeypox into hospitals because of exposure prior to development of lesions. This is the flu season from Australia. It's on the Australian Ministry of Health website, so you can all pull this up. The red is their season. You can't even see the two green lines, which were the 2020 and 2021 season. You can barely see it under cases. So the top is hospitalization, the bottom is cases. Two things to be aware of. One, the flu season was early and significant. So this is why it's critically important that we have flu and COVID testing available in the hospitals next. So what have we learned in the last 2.5 years? We know that coronavirus surges are predictable in geographic patterns. We know that generation of variants is predictable in a pattern. 100% of the variants that cause significant community spread in Europe cause significant issues in the United States. And so we know these things, and we need to utilize this information. We know also that herd immunity cannot be obtained or sustained with our current vaccines. So COVID will remain present until we have a more durable vaccine or a more mucosal generation of antibody vaccines that may protect against local infection in the nose. Vaccines and boosters we know are protective, but we also need to recognize that a significant number of people over 70, as that protection wanes, within 4 to 6 months, a significant number of unvaccinated and boosted individuals had fatalities from Omicron. So vaccine development, as you know, relies on the illustration of natural immunity, and that provides our roadmap. I think it's really important that every healthcare worker can really explain to every patient the difference between the COVID vaccines and the vaccines that most people are aware of measles, mumps, rubella, polio, and smallpox. All of those diseases produce long-lived immunity, and the vaccines produce long-lived immunity. In fact, herd immunity may last for decades. Natural COVID infection does not induce long-lived immunity against reinfection. We could see this in December of 2020 when we saw the second outbreak of community spread in South Africa with the Beta variant. We need to use that information to make it clear that the purpose of these vaccines was protection against severe disease and hospitalization, because I'm very worried that what will happen is people will interpret the findings of the COVID vaccine, which is really protecting against severe disease and not producing herd immunity, and mix that up with the vaccines that we use in childhood, which really induce long-term herd immunity. So just to remind you, this is the data from measles, mumps, and rubella vaccine. You can see that the protection literally lasts years and years, and this is with definitive follow-up following measles vaccine. This is polio, and we know both in the US, of course, we have this outbreak in New York right now, but in general, polio rates in the United States have been enormously low. Next slide, and around the world. This is global polio. I should call your attention to that little spike in 2021. So it's not just the United States that are experiencing some resurgence of polio based on poor immunization rates during COVID. Of course, with monkeypox, those of you who are born before 1970 probably received smallpox vaccine. The protection is long-lived, and you may be protected even against monkeypox. And we haven't had significant smallpox. Obviously, it's been considered eradicated because of vaccination. So what about COVID-19? What have we learned in following this all through the last 2.5 years? We know now that natural infection does not induce long-lived immunity and does not result in protection from reinfection. How do we know this? This is the data from South Africa. South Africa has done an incredibly good job in both testing and tackling sequencing, as well as doing antibody studies with that original surge, showing that up to 50 to 70% of the population was infected with the original SARS-CoV-2. That did not protect them 4 to 6 months later from a beta surge, 4 to 6 months later, a delta surge, 4 months later, an Omicron surge, and 4 to 5 months later, an Omicron B4, B5 surge. And so we have very clear evidence that there is no herd immunity induced by natural infection with SARS-CoV-2 or its variants. We also have great documentation about vaccine effectiveness against protection against infection. And this is the data coming out of a series of models looking at 50% decreased protection from reinfection by 5 months. This is a recent paper published in a British medical journal. This looks at both protection against infection and protection against severe disease. It was a very well done, comprehensive analysis of all the studies to date. You can see by 150 days, those over 65 had lost protection against reinfection. The same being true with those under 65. Protection against severe disease wanes significantly by day 200. So what about severe disease, hospitalization, and death? And what are the risks to our frontline healthcare workers? This just looks at hospitalization rates per 100,000. This comes out of the Department of Health in Washington State. They have some very nice data. This is over July of 2022 with Omicron B2 and B5. And you can see the protection against hospitalization is about 3 times better if you've been vaccinated. I just call your attention early on, people were talking about 100 times and 1,000 times. This is 3 times as protective as being unvaccinated. And so vaccines do not make you into Superman. Healthcare workers are susceptible both to reinfection and also potential for hospitalization, although it's 3 times the protection against about them being unvaccinated, but still not nearly the protection that was originally cited. So this just looks at different rates, again, from the Washington State and from all of their data showing the level of protection against severe disease and hospitalization, showing where their data came from. So what are our lessons learned? What we know is knowledge is the most powerful tool, and communicating that knowledge becomes clear and important to all Americans. Today, we have the equivalent of 2 large aircrafts crashing each and every day and killing all occupants on board. I can tell you that there would be an outcry at the FAA if this was happening on a daily basis, and there would be policy changes and deep data dives, and we would be making a difference in how we executed the tools that we had. And yet today we have over 300 deaths a day, even in our laws between surges, and we're headed into the fall. So I think it really should be a call to action where we treat every hospitalization and every death as a failure of our programming. And when you take that approach, it's the same approach we took in sub-Saharan Africa to stem HIV. And when you take that approach and you find the gaps in the programming and you fix those gaps of implementation, you can save people's lives. I know we are also tracking increased susceptibility to other infectious diseases. You're seeing this with rise of multi-drug antibiotic bacteria resistance and fungal infections. When populations have increased issues related to hospitalizations and people who have had significant serious illnesses in the hospital, it is a setup for other infectious diseases. So this is what I'm projecting as our the first 2020 and 2021 are the actual number of deaths that occurred each of those years from January to the end of December. There will be between 275,000 and 300,000 deaths this year, despite Paxlovid, despite vaccination, telling me that we are not fully utilizing the tools that we have to save American lives. I think you know that the annual flu deaths are modeled because we weren't diagnosing flu definitively laboratorily. I hope we do that in the future. You cannot syndromically track infectious diseases. You must definitively diagnose them. But previously, we ran between 35,000 and 50,000 deaths on a flu season. So you can see this magnitude is significantly greater than that. There was suggestions that both the Delta variant and the Omicron variant would be less deadly. It is true, the Omicron variant, and I think this has to do with additional tools that were available as well as the vaccines, but I want to make it clear the Delta variant last summer was 40% more deadly than the summer before. So can't just predict what these variants are doing based on what other countries see. This is the current daily hospitalizations, and this is the longest area under the curve of prolonged elevated levels of hospitalizations from COVID, particularly in those over 70 that we have seen since the beginning of the pandemic. So going into the fall with already significant number of new admissions on a daily basis for those over 70 or also risks for a significant flu, you can understand my depth of my concern. The other thing is, we have a habit of aggregating all of the data nationally. You have to look county by county, state by state, because large states' improvements can hide deterioration in other states. I just call your attention to California versus South Carolina. People were talking about hospitalizations improving, but that was largely because of the large populous state California was improving because it was deteriorating in South Carolina. So data must be utilized locally in order to really combat pandemics. So you've heard about the impact on life expectancy, and I wanted you to see this because what this points out to me is for decades, we've been not addressing the issues related to access to healthcare between Hispanic, Black, and our Native Americans. No matter where they live in the United States, even before COVID, life expectancy was lower, particularly among our Native American populations. This was not addressed. It was simply mapped. And they have lost the most ground of all of the race and ethnicities due to COVID and have the highest fatality rate. Of course, also the highest fatality rate are those individuals over 65 and between 40 and 64 with comorbidities. But those under 65 are just dwarfed compared to the fatality rates that are high and remain high in those over 70. Now, it's true that Delta and Omicron were less fatal in the UK. And when you look at what was the difference between the UK and the United States, particularly during Delta and then into Omicron, very similar vaccination rates throughout Delta. But when you correct for population, they had significantly less deaths. The only thing significantly different between the United States and the UK was access and the utility of testing. And so if you test and you provide tests to the general population, young people will test and they will isolate if they are infected. They understand the risk to their family members. And when you make testing available, you can dramatically decrease community spread and the rate of infection of vulnerable Americans, as they did in the UK. They were testing at 4 to 5 times our rate. So what about long COVID? Long COVID remains a definitive threat to every American. The risk increases with each and every COVID infection. The trouble with long COVID is we're grouping two pieces together. We're grouping people who have had serious hospitalization and a prolonged recovery with those who are younger and have brain fog and fatigue. We need to separate those. We need to define it. We know that even mild disease can lead to long COVID. There's also a divergence in the literature about whether vaccines are protective or not. But it's clear that vaccines do not provide a high level of protection against long COVID. We need to also explore the relationship with Paxlovid. But long COVID is not only leading to significant disabilities, we have about 4 million workers on disability because of long COVID. It's also increasing significantly depression. So then what about COVID by age? And so I think it's really important to have common sense data to our healthcare workers, our hospital workers, our community workers, our essential workers, so that they understand the risk by age. Obviously, for those under 35, the biggest workplace risk is asymptomatic transmission of those under 35. Many of them will not have symptoms, rare to have severe disease, but also a risk for long COVID. 35 to 60, depending on the comorbidities, can have both a long COVID risk and a severe disease risk. And then certainly our highest risk group are those over 60. And so that's why it's really important to continually push for boosting in that age group. Concerning to me are the brain findings and the post-infection new onset diabetes and cardiovascular events. This is quite serious, happening at 6 to 12 months after infection. We still don't know whether the vaccines or Paxlovid will decrease those rates. So research that needs to be done. I just want to talk briefly about rural America because COVID really laid bare access issues in our urban areas as well as our rural areas. Our rural areas population is older, it's often poorer, often higher rates of comorbidity, less access to primary care physicians, less access to subspecialty care, and less access to highly technical care. A hub and spoke model was created with regional hospitals, and many of our community hospitals could not get access to regional hospitals because regional hospitals were already full with COVID patients. Death rates have been higher across the South and our rural areas for more than a decade. So I'm going to show you those slides really quickly. This shows you that our rural population, as shown here in green, is older. Young people are concentrated in urban areas. This is child poverty, and you can see child poverty rates high across Appalachia and across the South and in our tribal nations. Obesity rates, again, higher across the South and Appalachia and our tribal nations. And this is from 2008. So we've known this, and we have not addressed really the epidemic that we've had of obesity, diabetes, and hypertension. This is access to level 1 and level 2 trauma. And although this is continuing to improve, I'm just showing this as a surrogate. So you will understand and know that there's a lot of America that is not covered either by helicopter or ambulances within that golden hour. And that's deeply concerning to me. So I think we really have to look at these issues about access to highly technical care to really understand why people, particularly in rural areas, are dying at higher rates. It is not just how they voted. It is not just whether they're vaccinated or not, but it's also access to critical healthcare parameters. This shows the level of fatalities that has been age corrected. This is from 2014. Look at the orange and the yellow down through Appalachia, across the South, across northern Texas, into the Panhandle, into Oklahoma, and our tribal nations. And so we've been tracking higher fatality rates across the United States by these counties for more than a decade, yet we have not changed it. And this really has to do with access and access to care and structural barriers of access to care. And those persist today. There are urban pockets, but there's also rural pockets without access to primary care. And so I wanted to end on a positive note. We have the tools and the lessons for controlling pandemics. We've done this in sub-Saharan Africa. We dramatically increased access to treatment and prevention services and dramatically decreased new incidents of HIV and fatalities from HIV. And indeed, the cohort of patients with HIV in sub-Saharan Africa went from 3% over 50 to almost 25% over 50, showing that you can really change and keep people alive if you use the tools that we have, but we're not using them in America to make sure that every American can not only survive, but thrive. And that requires, number one, that all infectious diseases have a definitive diagnosis. We shouldn't allow any hospital or clinic to code for a community-acquired infectious disease without a definitive laboratory diagnosis. We cannot run programs based on presumptions. We think you have flu, so we're going to code it as flu. That's what got us in trouble with COVID. We didn't see it coming because we were making presumptive diagnoses for flu rather than laboratory diagnoses. And if we had had laboratory diagnoses, we would have seen COVID at least 4 to 6 weeks earlier. So we need to make, number two, all community-acquired infectious disease, now I'm saying community-acquired rather than hospital-acquired, all community-acquired infectious disease reported through existing EMR systems, anonymized and available to everyone, including the community, so that they know what infectious diseases are circulating in their community. I think we need to require NIH and all institutions to invest 20% of their research dollars into rural health research and behavioral science. 20% of Americans live in rural areas. There are strong academic institutions that could support this research that are already receiving NIH funds. Number four, we need to increase accountability, requiring CDC to engage locally, to devolve into a decentralized organization that's embedded in the communities. You battle pandemics on the ground in the community, not from Washington or Atlanta. And then number five, require the CDC to report annually on progress across all our pandemics. Progress in implementing programs combating obesity, including childhood obesity, diabetes, cardiovascular disease, opioids, anxiety, depression, COVID-19, and monkeypox. We need to really have a public health system that's accountable to the community, using data with the community to drive decision-making. We need to require progress in urban and rural settings across gender, race, ethnicity, and geography. And that means that you get the data in an anonymized way so that you can really track whether people have structural barriers to access, deploy new tools, and see if it improves access. And then finally, to reestablish trust with America, we need to ensure that all guidance is accompanied with the data supporting that guidance, and that will help to reestablish trust within the public sector. I'm just going to show you where we have been over the last 30 months that shows the predictable surges. And this is another reason why COVID deaths may be higher in certain regions of the country. It's because certain areas of the country have two surges. The South has both a summer surge and a fall-winter surge. The upper Midwest or Northeast really only has a fall and winter surge, and then a small, we can call it a swell in late summer and late spring. And so we really need to incorporate all of that information. This is where we were in January of 2022. I call your attention to the level of community spread that was documented, the level of hospitalization, the level of fatalities from Omicron. This was just 8 months ago. Things always improve in February, and they improve throughout February into March. This is that little swell that we have in the upper Midwest and the Northeast. This was the B2 variant. The year before, it was the Alpha variant. And then you can see what happened in May. And then the summer surge starts in June, goes into July. And then can either trigger, we're carrying high number of cases into the winter and into the fall. This was just last week. I call your attention to Kentucky, Tennessee, and West Virginia, Northern Alabama and Mississippi, Northern Louisiana, carrying these number of cases into a potential fall surge is a lot of potential for high levels of community spread. And this is just after schools were started. This is going to continue to accelerate. And so I just want to leave you on that optimistic note that we have 21st century tools and the knowledge to ensure that every American is safe from hospitalization and death, independent of age, if we use the tools we have. Yes, it's vaccines and boosting, but it's also proactive testing so that particularly those over 65 can immediately access Paxlovid, which will mean testing in the house and telehealth for particularly people in rural areas and people in urban areas without access to a primary care clinic. Of course, N95 and KN95 masking for those at risk for serious disease during surges. We had EvoShield. We now have data to suggest that B4 may be so evolved that EvoShield is no longer helpful. This is going to be a problem, and we need to really continue to study monoclonals and combinations of monoclonals for those who cannot develop a significant immune response to vaccination. Certainly, proactive testing is absolutely key. And then we really need the research on long COVID. We cannot afford to have two things happen this fall: loss of 20% of our healthcare workers because, again, get infected during the surge. We know what impact that has on our airline industry, our healthcare industry. We should not accept that as a given. That would just accept that level of infection because that will lead to increased cases of long COVID. So finally, yes, we have everything we need to ensure that we all survive and thrive, but we're not using data and the tools in real time to strategically and temporally protect Americans and give them access to life-saving treatments that they would need during the surges. We should never accept this level of fatalities as a given. I can tell you, if I took this approach to combating HIV/AIDS in sub-Saharan Africa, we would not be at the place and on the threshold of controlling the HIV pandemic without a vaccine. So this is what's possible when you use data. Thank you very much for your attention.